relationship, like a big family, as already said, as a big brother, young brother, all know with family to family very closely. This is what I would like to, the same thing. Why I'm telling this to you is just to tell you that the same spirit and the same relationship should develop with your colleagues. Not only pediatric surgeons, but whoever working as a colleague, you should also socialize. This is very important. It's not only important for your social life, but also even for your professional life, because most of the discussion which we make is, we discuss them with very informal ways. So this is part we should also entertain. Our trainees, as you see them, they are very vibrant in leadership. We always encourage them and push them to participate in leadership. And as you see, now they are becoming a global known leadership like Netina, Hannah, Ubedel, and the others are also coming. So I think they organized this famous Ethiopian women in surgery group, the first group, and I don't know how it's going now, but this is their achievement. So, most of the time professionals think leadership is not my duty, and my duty is to do my job, which is surgery. That's a wrong conception. The only person who can understand you better is yourself. And the only person who can understand your profession better is yourself. And also the service and whatever it is. So it's not an additional work. Should be something you should encourage. You all should be encouraged to do. When I was appointed as a dean, I said no. I came from Canada to start fellowship in pediatric surgery and also to start and expand simulation lab. That was my aim. So when Professor Andrea said, we want you to be dean, I said no. And then he said, why don't you want to be a dean? And I told him I have these plans in my life to do in the coming years. And he said, he's a philosopher who knows that. He said, if you want to drive the car, you have to sit behind the wheel. So if you are there, you can do whatever you want to do. Otherwise, you have to beg people to do. You may not even do what you have planned. And he said, I didn't agree with that, but I left, and at night, sleeping, I was very eager to go and see him and say, yes. I said yes, because then it was true. You can manage the institutions the way you like when you are on the leadership, instead of asking somebody to do your thoughts to be implemented by another person. So don't shy away from leadership, in any kind of leadership. You have a lot of, you don't know, but all of us has a lot of potential to be a leadership. So I think this is something you should also practice in your life. So this is a family tree of pediatrics, as you see. The elderly are from above, but now we've gone all the way down. This is most of them are trained, or almost all of them might have passed through Black Line. So this is, now we are one big family, the pediatric surgeons. So we all now, because we have the same target, same objective. So there should not be any reason why we cannot be one family. It's very difficult to belong to BBC. You know BBC, yeah? See, do you know BBC? Huh? No. What's BBC? BBC? British Broadcasting. Yeah. But it is also born before computer. for us. For you, it's just like talking the language. For us, we have to learn. This is what I already said in my speech, so you can see how we are progressing to give the service. We have now a good faculty development. We have 2 full professors, 3 associates. I think with the quality of faculty or staff, I can say pediatric surgery is most privileged. And this is all in a short time. We started the training in 2011. Now in less than 12 years, we have all these outcomes and also the faculty development as well. Next focus area will be faculty development. In a way, all this pediatric surgery, general pediatric surgery has to go to subspecialties. Now, maybe 5 years from now, we'll have a separate session for pediatric urology, pediatric neonatology, pediatric oncology, pediatrics, whatever it is. So I think this is what we are planning to do in the coming, our task in the coming 5 years. The research output is also high. I think, I don't have the exact number, but I see a lot of research publications from pediatrics unit. The leadership capacity is what I already mentioned to you. And as a result, we have improved morbidity and mortality in our patients. Not only increased in the number of surgeries, but also the morbidity and mortality are improved. Neonatal surgery, like tracheoesophageal fistula, during my time is like less than 10%, not even maybe 5% survival. We try to avoid them because we don't make approach. So without a good intensive care, neonatal ICU and staff, without supplement like parenteral nutrition and good antibiotics, whatever you do will not be successful. But now we have very encouraging results. We have reached close to 40%, even though now the order to reach about 95%. The abdominal wall outcome also has improved. Interception is now was one of the big challenges we have. Like there was 70% mortality in interception during my early time, because most of them, almost all of them come after they are gangrenous, complicated ones. But now we have 70% of interception are not operated. They are reduced by hydrostatic reduction. We used to do 3 surgeries for anorectal malformation. Now, some even have started to do with 1 surgery, just direct go through, and the other one with some, but most of us will do with 2-stage surgeries. And hypospadia was also something very challenging in the management, but the outcome from the previous studies has shown that it's improving a lot. Now, we start knowing more about this subject, and we get time also to update ourselves with the new findings, the new methods of management as well. I think the last page which missed is to say thank you. I can say it by, I don't have to say thank you. Thank you so much. This is.
Takeaway is definitely leadership, teamwork, and family. So we'll move on to the 3rd session, a scientific paper presentation. So I'll ask the chairpersons to please come to the stage. Dr. Seifu, Dr. Salamlak, and Dr. Shagri. Presenters, as you know, since we're running short on time, case reports, you have 5 minutes for your presentation. For those who are presenting.
Isolated primary hydatid cyst of the nasal colon. So this is the outlines of the presentation, the introduction, the presentation, and discussion, and conclusion. I'll go through the. So the introduction, as you know, hydatid disease is a parasitic infestation caused by different species of type 1 called Echinococcus. There are greater than 6 known species of Echinococcus. However, only 3 of them are known to be pathologic. Echinococcus granulosus, Echinococcus multilocularis, and Echinococcus progeny are the species known to be causing pathogens. And there are different types of hosts for Echinococcus life cycle, and to cause a disease. There are actually different literatures, they might get 2 hosts, 3 hosts, and so on. But commonly it's stated as there are primary, secondary, and accidental hosts. So primary hosts are, as you know, the deviative hosts, which are the carnivores, the dogs, and the hogs. And the secondary hosts are the intermediate hosts, which are used in the life cycle of the hydatid cyst. These are sheep, cattle, and other herbivores. And the accidental host, sometimes also called as accidental intermediate host, is the human. So human being acquires the infection either with direct contact or with eating contaminated food. So as you know, it's common in sheep farming countries like Mediterranean countries, Asian, Australian, North and East Africa, and also in Latin America. And it affects all parts of the body except the hair and nail. Common sites, the common sites of involvement are the liver, lung, and the kidney. And actually about 80 to 90% are confined in the liver and the lung. And what's unique to pediatrics is, as you know, in adults it's very common to find it in the liver, which contributes about 50%, but in pediatrics it's commonly found in the lung, nearly equal or higher than the liver. So the rare locations are the peritoneum, the omentum, and the mesentery, which is found in 2% of the cases. This is actually the one of the report that I am going to present. This is specific to primary hydatid cyst located to the peritoneum, omentum, and the mesentery. However, secondary hydatid cyst located in the peritoneum, omentum, and mesentery is quite common, which can reach about 30% of the cases. This is secondary to either hematogenous spread or local rupture, especially in patients who have liver hydatid cysts. So I'll go briefly to the case presentation. Our patient was a 5-year and 7-month-old male child, present with features of acute abdominal pain of 1 day duration. And physical examination, he was acutely cyclopic, he was tachycardic and febrile, and he has diffuse abdominal tenderness. And he was investigated with, he came with ultrasound, and the ultrasound showed multilocular separated mass, mainly located in the right upper quadrant. And this was the number of hydatid cysts reported in the country distribution. So far, only 2 cases of high diagnosis and treatment. There are different diagnostic modalities and treatment modalities suggested. This is the conclusion. Thank you so much. Just to save time.
Okay, thank you, Victor.
Countries it's more diagnosed in the neonatal age, whereas in our setup in developing countries is more of a diagnosis at the infant or even later age. In our setup, the reason could be, because of poverty and because of ignorance. Families may not consider it as an HSD. They might consider it just a constipation. They might be managing it with different methods. That may be the reason that it's going to be delayed. But most of the time, the presentation in the developing countries is a bit late. Besides that, the problem in our community is the equipment, the materials, the professionals, they are inadequate. So because of that, we are not adequately managing our patients, timely managing our patients. And also there are lacking research. We don't have a lot of, when I was doing this research, it it was difficult to find published papers on Hirschsprung disease. There was only one paper which was published with the radiology department, and there was another paper which was an assessment of those patients that were done with transanal pull-through alone. Otherwise, it doesn't tell the pattern of Hirschsprung disease. So the study focused on assessing what the pattern of this Hirschsprung disease is in our institute. It was a 5-year retrospective chart review, and we tried to add phone interview to assess the one-time status of their, it is not a longitudinal study, but at least with a phone interview we want to see how the patients were doing. And the subjects that were included were children who were having histologically confirmed HSD, and they were already managed with a definitive procedure. And the operational definition of our outcome, we say good functional outcome if there was no complaint with a stool passage, and at least every 2 days, at least less than 2 days of frequency. Satisfactory if it happens more than 2 days, or if there is constipation that needs a laxative. And poor functional outcome if there was a frequent distension and severe constipation which needs enema. And ethical considerations were assessed. And the result was 56 cases were included. And the male to female ratio, which is similar to other studies, male were higher. When the aganglionosis was longer, the ratio between male and female gradually narrows down. In ours, also it was 4:1, a bit lesser than that of the general male to female ratio. We had one patient who was aged 20 years, otherwise the age range was neonatal to 20 years. The age at diagnosis, majority of our patients were diagnosed during infancy between 1 month and 1 year. And different literatures, it shows, as I said earlier, in developed countries, they are more diagnosed at the neonatal age, less than 1 month, whereas in less developed countries, they are diagnosed even after 1 year of age. We serve a larger population, starting from Gambela to Welega, and also the southern nations. The average maternal age was 29, so clinically the patients mainly presented with abdominal distension and failure to pass. And majority of them had abdominal distension, whether it was a presentation they initially complained or not. The majority of our patients, they present acutely with obstruction, 34%, and few of them, about 10%, they present with enterocolitis. Enterocolitis is a main presentation in the Western, but in our community is a little bit lesser presentation. Maybe our gut is already used to the parasites and the bacteria of the environment. We had 2 patients with colonic perforation and 1 with small bowel perforation. And in Tanzania, it has relatively a similar kind of study, with 58.2% of complete obstruction and 38.2% presenting with chronic constipation and 3.8% of intestinal perforation. They didn't have any patient with enterocolitis in Tanzania. Delayed passage of meconium, we know that this is a significant indicator for Hirschsprung disease. We found it in 84% of the patients. Also in the West, it's really very important finding. Associated congenital anomalies, in 10% we had Down syndrome, and in 5% we had Andersen testis. I tried to see if the Down syndrome was associated, and in Tanzania it was only 1%, but Kenya is relatively similar to that of us. But a study done by Prem Puri and also many associated other researchers, they found that 15% of their patients had Down syndrome, and these patients had associated poor bowel function. 48.2% of our patients were undernourished. 15 had leukocytosis, 7 anemic, 1 had no albumin. And sad story is, I wish our radiologists would have been here, we don't have a contrast study in Japan because of lack of radiologists, but hopefully we'll start soon. And so full thickness rectal biopsy had to be done for all patients that we suspect Hirschsprung disease. And we need to do repeat rectal biopsy in 29% of them for inconclusive results for many reasons. Maybe it was inadequate or the pathology were unable to make a diagnosis. So the level of aganglionosis, most of them were short segment, 90% of them, 9% long segment, and ultra short, only one case. And this is also similar to other studies. Stoma had to be created for majority of our patients except one for whom we need transanal pull-through, first single stage. And in other studies, it was level dependent. In Japan, in Tanzania, it was similar. In the Kurambasa, there is one study which assessed total transanal rectal pull-through without colostomy for 6 years with 47 patients. So the median age for stoma was 8 months, and stoma type was these types, and median duration was for surgery was 4 months. So I'm going to be rushing for sake of time, but I tell you also the juicy part. So definitive surgeries, Weinstein was the main type, and in other studies also nowadays they are going more in line to transanal rectal pull-through without a colostomy. That is the current trend of the world, but still Swenson, Warman, and Suave are practiced in different parts of the world. Average duration was 168 minutes, and so the outcome, early post-op outcome was found in 53.6%, which was comparable to Tanzania's as well as the Ethiopian study. And the most common were acute obstruction, pericarditis, and perianal exploration. And the average duration of hospital stay was 10 days, which was significantly associated with post-op development of post-op complications. Those that developed complications stayed a little longer. The mortality rate was 1.8%, which was comparable to other studies. And redo pull-through had to be done for 4 patients. 2 had stricture and 2 had transitional zone pull-through. I saw a paper of a 29-year review of 256 patients. They had to have 5 redo procedures. Ours seems to be a little more. The other is for transitional zone pull-through. Studies say that it is now conservative management is better because it doesn't have to be operated all the time. And they have seen for 11 children, they managed conservatively 6 of them with latex and 4 of them with Botox, and the patients were fine and they had to...
I think it is time, Dr. Gerstens. We have to stop here.
Yeah, I fast or stop?
Yeah. Just take a minute and then try to wind up.
Thank you. I think this is going to be 2 or 6 slides. Okay, so the long-term outcome, constipation was in 28.6%, and soiling was in 14 patients, so similar to other studies as well. And association, there was no significant association with congenital anomalies or redo surgery, whether we did a redo surgery or not. It was not associated with a late outcome, with age of definitive procedure, sex, or timing of colostomy or level of aganglionosis. In our case, there was no association, but in some papers, they say that age may have an association with transanal pull-through. After the age of 7 years, if you do transanal, it's better to do it before 6 months. So for sake of time, I'll just go into conclusion. Majority of our patients presented between 1 month and 1 year, and they came with obstruction, and rectal biopsy had to be done for diagnosis. Short segment was the commonest, and we did stage surgery. Early post-op complication was significantly associated with poor late clinical outcome. And even though our patients had satisfactory functional outcome, but we need to study it more to see the long-term outcome. Thank you very much.
Okay. The next presenter will be Dr. Abraham Maria, our emergency separation of conjoint units, experience from low resource settings. It's a case report. So we have 5 minutes, trying to finish with this time.
Okay, thank you. So this is actually a case that we encountered when I was still a medical student. Currently, I'm a final year general surgery resident. So we encountered two cases. The first case was when I was a C1 student, and the last one was when I was an intern. So we had to do emergency separation for both of the conjoined twins. So this is the first case that we encountered. So I will leave the basic part out due to the sake of time. So the first case that we encountered were the conjoined twins that presented to us on seventh day after seventh day of birth. So they were initially referred from the Abraham area, and the mother did not have any follow-up, and the conjoined nature of the twins it was actually detected in intra-op. So when they presented to us, what we found was that the patients generally had stable vital signs, but during the pre-op assessment of the organs that they shared, we found that they had a single pericardium, but they had separate hearts, and there was a breach of myocardium between their left atrium that was not clearly defined in the echocardiography or the CT scan that was obtained, and they had a small area of hepatic fusion, and they appear to have a separate peritoneal cavity. So what we did was the elective surgery, elective separation was actually planned, and the plan was to do the surgery after the neonatal age. But what happened was that on the third week after birth, so one of the twins died. So the twin B actually that's shown here. Twin B actually died. So the elective nature of the surgery was changed to emergency basis. So emergency separation was done. So the surgery actually took 3 hours. There was minimal blood loss, and the intraoperative condition was stable, and the immediate postoperative course was also stable. But starting from the first postoperative day, the separated twin actually started to develop cardiogenic shocks. Secondary to poor cardiac performance, the patient became cyanotic, bradycardic, and despite our best efforts, we could not salvage our patient. And the second case that was encountered, they were the Omphalo-Shopagas twins that were born to a 90-year-old Parawan mother, and the organs that they shared were actually more extensive than the first one. So during our assessment, what we found was that there was a fused liver, and there was a fused pelvis as well as perineum. There was a shared one umbilicus, there was a shared colon, there was one penis, and the scrotum was empty, and they shared one bladder, and there was no anatomy. So the plan was also to establish a multidisciplinarity and operate these conjoined twins on an elective basis, but during the second day after presentation, they started to develop signs of intestinal obstruction, and the elective nature was also changed on emergency basis. So emergency separation was attempted. So what we found in trial was that there were 2 sets of ileum that can be seen. The joining to one terminal ileum that was around 5 centimeters from the ileocecal wall. There was one colon which was grossly distended, and there was one rectum which was joining to the bladder door. And in the rectum are 2 mesenteries separated by that was supplied by either twin. And there was a bridge of tissue that was connecting the 2 livers. And the patient, they had 4 ureters, 1 bladder, and 2 intra-abdominal testes that was found in the pelvis of twin B. So what we did was, so the equitable distribution of the organs was not possible in this case. So for twin A, we constructed a colostomy, 2 ureterostomies, and we divided the rectum in a longitudinal basis and gave half to each twin. And twin B got the penis as well as the 2 testes, and an ileostomy was constructed and a mucus fistula, and half of the divided rectum was given to the twin B. But despite our best efforts, during the surgery, twin A arrested, and the twin A was revived, and both of them were transferred to the NICU while still intubated. But despite the best efforts, the first twin actually passed away 8 hours after the surgery. The second twin passed away around 48 hours after the first surgery. Both of them had developed DIC, and in trial they were also transfused with around 1.5 times their total blood volume. So what we wanted to discuss is that we are not trying to present a success story. We are trying to present a milestone for pediatric surgery in Ethiopia, because such attempts were not possible in the years before that. But there are lessons that we have to take. So the preoperative planning, so the establishment of a multidisciplinarity is of vital importance. The intraoperative considerations are also vital as well. And airway positioning and vascular access and monitoring, they pose a significant challenge to us. The post-op management was also very difficult, and the issue of informed consent was hard, as both of the first babies they were abandoned, and the second one, the families threatened to abandon them unless emergency separation was done. And there was also an ethical dilemma about distribution of the organs. So this is what we wanted to present. Thank you.
Thank you, Dr. Abraham. So the last presenter of the session, Dr. Daniel. So he's going to present about patterns and outcomes of urgent cloaca surgery in low setting. So we'll have 7 minutes.
Discussion. So it is a 10-year experience in the Columbus Specialized Hospital, and as an introduction, we know cloaca malformation is one of the severe anomalies for female anal malformation. It accounts for it occurs in about 1 in 2022 to 125,000 live births, and it accounts for approximately 10% of anal malformations. In the study done by Professor Amazana showed from female anal malformations in Ethiopia, it accounts for around 7% of the patients. So it's seen exclusively in females, and complete workup starts with physical examination and possible examination and anesthesia combined with imaging. So the first 24 hours for any airway patient should be focusing on Bacter screen, and in addition, specifically for cloaca patients, we have to look for hydrocorpus, because the management will be either to do diversion only or to combine it with hydrocorpus drainage. So always the principle is to, before doing the definitive surgery, we have to know the anatomy before doing the surgery by combination of contrast study plus endoscopic study, that's with cystovaginoscopy. So the goal of treatment is to restore the 3 openings with preserved function. For the urethra, with continency and protection of the upper tract. For the genitalia, to allow for normal sexual function, and for the rectum, to achieve for bowel routine. So surgical therapy has significantly evolved after introduction of PSAP and total horizontal mobilization by PINA. So previously, the management was primarily depending on the length of the comment channel, but the recent studies show the length of the urethra is also important. So it's known for less than 1 centimeter and about 5 centimeters cloacas, but the comment channel is between 1 to 5 centimeters. Even if the comment channel is less than 3 centimeters, if the urethra length is less than 1.5 centimeters, we have to remove the mental separation. This is the key difference from the previous management. So the statement of the problem is one of the complex anomalies from female anal malformation, and the anatomy is also considered to be complex. The surgery is also considered to be one of the most challenging one, and some of the techniques are not reproducible. So the Columbus has been the major center for decades, operating specifically patients with ARN, especially patients with cloaca, because I've tried to contact most of the surgeons that were working in the periphery. We are not operating mass patients, more than 2 patients, but most we don't know the presentation, the outcome of patients who are operated in the Quran. So the significance of the study is going to be the first published report for the Quran Hospital, plus it's going to reflect the outcome of that surgery in addition to the pattern for our own setup plus low resource limited settings. And worldwide, even most of the studies are in general focusing on the whole female anormal malformation. So they are not specifically studying about female, specifically about cloaca, so our study is going to be an additional input. So these are the objectives, and it is a retrospective, cross-sectional, descriptive study. And so we collected the data with chart review plus phone calls, and we have used structured questions. So coming to the results, the median age at presentation was 17 days, and in Pakistan study it was about 4 days. Majority of the patients were from oral region, almost half of the patients. So antenatal detection is different from setups to setups. For example, in Korea, that accounts for 57% of the patients were having evidence of cloaca on antenatal examination. But in Egypt study, none of the patients were detected antenatally, and in our study as well, there is no any patient whose anomaly detected antenatally. Presenting symptom, majority of the patients were present with single perineal office. There was no mass patient who present with bowel obstruction and sepsis. So as you can see from the referral diagnosis, you can see all patients were properly diagnosed with cloaca. This is a simple physical examination, but majority of them were diagnosed with rectovaginal fistula and simple perforatanus or ARM. The commonest colostomy that's been common in the textbooks is to do divided colostomy, but our setup, you can see 72% of the patients have no colostomy. And most common site is the proximal segment colostomy in our setting. So coming to associated anomalies, 1 out of 4 patients were having renal agenesis of the solitary kidney, and 15% of patients had hydroglobus. So coming to the preoperative Bacterial screening, in 72% of the patients, spine X-ray was not done or it was not documented. 93% of the patients sacral ratio was not calculated or was not documented, and 69% of the patients spinal ultrasound was not done. So preoperative study distal colostogram genitogram histopathology can be done in Quran Hospital, but distal colostogram is done only for 1 patient, genitogram for 9 patients, and histopathology for only half of the patients. So operative finding, 73% were having conventional less than 3 centimeters. Considering the urethral length, again, majority of the patients had conventional length above 1.5 centimeters. So the definitive repair was between 5 to 40 months. Median was 90 months. In Egypt, they did at the age of 3 months. Anormal component was primarily managed with PSAP, urogenital sinus usual, primarily by total urogenital mobilization. Only 2 patients required urogenital subparation. So colostomy complications were seen in about 20% of the patients. Anaplastic complications were seen in 37% of the patients, and usually the common complication was stenosis, and it was almost comparable with other studies like Pakistan, studies from Pakistan. So for the 2 patients for whom we did urogenital separation, both developed both urethral as well as vaginal complications. Perineal infection occurred in 17% of the patients. In general, we had 33 patients, so 33 cloaca patients. Out of those, voluntary bowel movement could be assisted in only 9 patients. And out of those, majority of the patients, as you can see, had voluntary bowel movement, almost 88% of them. Spontaneous voiding was achieved in 66% of the patients. Almost nearly half, 43% of the patients had pre-operation, and most of the regulations were for rectal component, either rectal stricture or recurrence. So the final outcome, 27%. So more than 1 out of the 4 cloaca patients have died, and most of them, almost 66% of them have died at neonatal age. So in conclusion, the common associated anomaly seen was renal agenesis, and the preoperative Bacterial screening plus anatomic studies were not being done properly. Urogenital separation was seen to have higher complications, and the days rate for cloaca patients was high, and the common cause of death was sepsis and renal failure. So the recommendation is bacterial workup should be done and should be documented. The anatomic studies should be improved because we have data available, so they should be done for all patients. And the reoperation rate, the complication rate was very in our study, in our patients, and further study is needed to assess the possible reason or the factors that are affecting it. So this is my study.
Okay, thank you, Dr. Daniel. So we'll continue with the discussion. So from the audience, an equation for each presenter. So I will invite the presenters first to the stage.
So until we accept more questions from the audience, I want to ask just one simple thing. How was the follow-up journey?
Yeah. Actually, there was almost complete excision with minimal split, which is controlled, and the patient post-operatively was also put on a bed as for 2 weeks. And we followed this patient until 9 months of post-operative period. And this patient had no vein recurrence. We have done abdominal ultrasound at 2 weeks, and 3 months, and 9 months. There was no recurrence of disease. And actually, the split was very minimal because we had considered mainly lymphatic malformation or mesenteric cysts, and upon dissection, it was we're dissecting and having a similar possibility of hiatus cyst mesenchymal, and with then that we were able to control immediately, completely excised.
Thank you. So I think it's better if you include this in, like if you are considering publication of this paper, this is an important point to be added. Because there was still the experiences that you shared about the use of albendazole for at least after 3 weeks there was no any evidence of intraabdominal recurrence.
At least the paper is clearly written actually. You can read it.
If there are no more questions, it's better if we proceed to the next presentation. And it's on pattern and outcome of surgical evaluation HST in University Medical Center. With questions.
What is the result by and the other question is how many of the students we are of the age of 3 years are of training brain age, so that our function was calculated. Thank you.
More questions? Dr. Hill, will add the question?
Okay, yes.
Okay, thank you all for this presentation. So my question is 29% of the study population, they need repeat biopsy. So this is a significant number to have a repeat biopsy. So what is the cause of inconclusive biopsy? Can we minimize this by improving our biopsy tissue transportation or by discussing with the pathologists? So is that enough? This 29% is significant. The other question is swelling is not in 25% of the cases, but on your conclusion, you said the significant post-operative complication is seen in 23% of the cases, which is constipation. So I need some elaboration on this 25% of swelling. This happens after 3 weeks after or before anything about the information on this.
One more question.
Okay, my question is also around the rectal biopsy. How did you approach the time you do rectal biopsy and wait for the biopsy result and then colostomy and then go through or do rectal biopsy and colostomy at the same time. And also, this time we usually see constipated infant very frequently because of this time most of the children are paid hormonal and we see more frequent patients with constipation. So without very study and directly going for rectal biopsy because much burden on the system and on the patient and on service also. The other point is among all the patients for whom you did rectal biopsy, how many percent of, if you are very rough data, how many percent of the biopsy result became negative for HSC? And these are my questions.
Okay, thank you very much. The first question was also done for all. I think you also answered the last question. The data that we had was for those patients who had diagnosed HSD and who had definitive procedure. So initially what we took was those patients who had already had the definitive procedure. So it means our rectal biopsy was already diagnosed. It is positive for HSD, and then our HSDs, our procedures were already done. This means there are some patients who will have a negative HSD. Rectal biopsy will not be ganglionic or will be ganglionic or negative for HSD, and so those patients were not included in this study from the outset. Okay, it will be it's a 5-year and it is challenging for us to get all the charts after the reason we just came. Without imaging, it's very challenging to, of course, we will be forced after doing rectal wash, if the patient shows significant improvement, and when we do rectal examination, there is a positive class sign, it's a challenge to just assume this patient to have a simple constipation, so we'll be tempted to do a rectal biopsy. And on the other hand, when we had a patient that very looked like an HSD, would again have a challenge on doing a colostomy, because what if this patient does not have an HSD, would have a colostomy unnecessarily. So this has been a great challenge for us, and we are communicating with the radiology team so that we have the contrast study started. The radiology team has not yet been starting this imaging. They have their own reasons, one of them being their number was inadequate. So when we started initially, this 5 years back means we had only 1 or 2 radiologists. We had very few radiologists that were overwhelmed with multiple activities. That was the reason that we were unable to start, but now they have even started fellowship residency program. So hopefully we will start soon. So I think the very minimum will has already been answered. So with regards to the age of assessment, we called every patient. I think one of the limitations was to assess what the age of this patient. I don't have that data, so it will be a challenge, a limitation for assessment of, because if we try to assess those under 4 years of age, it won't be an indicator that this patient is having swelling also, because we have to assess those above 4 years. Obviously, we had many of our patients in the infant age, that means 5 years means they are going to be now 5 years also. So this is the response that I have. With regards to the thing, maybe one thing that's missing, swelling, the percentage with swelling, we will check, but patients with constipation or patients with swelling, it's a mild one. These patients had given us a story of occasional swelling, maximum of twice per week, but it is staining of the diapers. So we didn't want to add initially all complications. This is a long-term complication, and the early complication is less than 30 days. Long-term complication is above 30 days. So in the early complication, there was no swelling. That was why swelling was not included, but in the long-term complication, yes, there was swelling.
Thank you, Dr. Irsam. I think there is one question which is not answered for you about whether what percentage of the rectal biopsies Yeah, but
the point was
yeah.
if we are going to do right hand biopsy for constipated patient, or we assume possibility of HSV without a barrier, that means this patient might be a lot. So if you do right hand biopsy for all these patients, obviously there should be some more negative reports. Because after barrier.
Now we have another research going on, mainly to analyze these points, like how many percentage of the patients who are coming with possible clinical pictures of HSV are negative, and how many of them will really require a level of colostomy, and how many percentage of this patient is coming possibly excluded from the diagnosis, as well as also for having a necessary level of colostomy, including as KDHS. We have another progress. Hopefully we will bring it next week. Next year, sorry.
So it's significant in December. It was a question, and what was the reason?
Okay, that's a good question. So the main is, with the progress of our pediatric, our HSCD surgeries, there was also improvement in the pathology reporting. So in the initial period of our pathology reports, they tend to not find these ganglion cells. They will say, oh, this specimen does not have muscle inside it, or this. They would have the same mucosa, they will see it, but they will look for ganglion cells. And they will also have some muscles in there, but they will miss it when they section it. So gradually this has improved, and the reason why we had higher rectal negatives will also be because of that. They would always say it is inconclusive, and when we send them again another report, they would keep us.
And the other important thing here is also from our observation, biopsies which are taken in another institutions tend to be less informative, and we are sometimes obliged to repeat these biopsies. So I think it's our duty to teach also general citizens how to make informed biopsies. So next question for next presenters, and I think we are behind time, and let's use only the next 3 minutes for next presenter. About separation of the conjoined units.
The consequences with the next year, so the sepsis was entertained. So what we want to emphasize is that in both of the surgeries, a multidisciplinary team is already in place, and an elective surgery was planned beyond the neonatal age, if that was possible. But what happened was that in the first case, one of the twins died, so it was we have to separate the other one. And in the second one, they took signs of intestinal obstruction, and we could not determine which of the twins had this intestinal obstruction. So we have to explore them in the second one. When the exploration was done, initially the plan was to go for a minimal type of surgery, but the family repeatedly insisted for a definitive separation of the twins, despite the high risk that was mentioned. In trial, it was feasible to separate them, and both the MDT teams, both teams, the 2 sets of anesthesiology teams, 2 sets of pediatric surgery teams were available at intraop, as well as hepatopancreatic biliary surgery was also available in the plastic, as well as orthopedic surgery was also available for the second surgery. So that was why we proceeded with that. But sepsis is a consideration that we have to involve for future surgery. So the reason why we wanted to present this case is because there is a high likelihood that we encounter surgeries in the future as well, where elective surgery might not be possible. So in that case, what should we do more, and what are the areas that we should improve? So this is the main area we should focus on, and that's why we wanted to present it.
Okay, 1 or 2 questions for the last presenter. The audience for nice presentations and a good participation. This will mark the end of the first session. of the morning scientific paper presentations. Now we follow up on. Thank you, and we follow up on the next presenters, the next session.
But despite this distribution, now we still frequently see that there is a high burden of cases in some hospitals, and there is uneven distribution of cases in between the different hospitals where pediatric surgeons are practicing. And we still frequently observe that the patients are presenting late with complications, so there is a delay in the management. And so no study has been done, so the aim was to assess why this is still going on. So when we assess the barriers to care or the delays in accessing care, it can be seen in three levels. So the first is the decision to seek care. The second one is after deciding to seek care, there might be a problem reaching the health facility. And the third one is after reaching the health facility, there might be a delay in receiving adequate treatment. So we try to see different factors in each of these areas that are possible contributors to delay in patients accessing care. So the aim of the study was to assess the magnitude of the delay of our patients, and also what are the factors contributing to the delayed presentation of pediatric surgical patients. And also we sent out a survey to the surgeons to assess the different barriers faced by the surgeons in the different institutions. Mainly we interviewed patients, 200 patients who are already admitted in the hospital. Ideally, this should have been a population-based study, but due to logistic issues, we opted to interview patients that were already admitted and operated at Blackline Hospital and interview them to assess retrospectively what problems they encountered. So I won't go into the details of the result. You can see it in the abstract book, but we've seen that around 37 patients, most of them were from Addis Ababa, but more than half, so around 60% came from outside of the city, which shows that there is still a lack of service outside of Addis Ababa, and almost half were elective and half were emergency cases, and the most common conditions were ARM, TF, and Hirschsprung's disease. And from the participant interviewed, 35% said believed that there was a delay in their children receiving treatment, and 21% believed that the child condition got worse due to that delay. And most of them complained of 72% tertiary delay, which is receiving care after they reached the hospital, but there was also significant delay in the primary and secondary levels. So time to reach or receive care varied. So time to seek care ranged. So some of them that were born already in the hospital went immediately around 13%, but the others stayed for about a few hours to up to 2 years to seek care. And after deciding to seek care to arrive to hospital, so it took them, some patients took them up to 2 weeks to reach the primary health facility, and some after the primary health facility to reach to Bambas Hospital, it took them up to 15 hours. And they had to wait for emergency surgeries, usually in hours, but elective surgeries, they have to wait up to 5 years to get the definitive surgery. So when we asked the reason for delay in each of the factors, there were a variety of reasons, but just to highlight the most common one in each labels. So on deciding to seek care, the majority of them mentioned the poor understanding of the disease as one of the major facilities, as one of the major reasons. And on the second level of delay, they complained of distance of health centers, and around half of them, and problems with transportation roads. And also at the primary health facility, there was a delay in diagnosis. This is actually the patients that reported that the physicians were not able to diagnose the condition. And there is no referral. Most commonly was lack of pediatric surgery, 65%, but also lack of OR and lack of ICU had a significant contribution. And after reaching the definitive hospital, that is, the study was done at Bambas Hospital, the major reason for delayed care was lack of bed and OR occupancy. So we also did a survey, sent out a survey to one pediatric surgeon practicing in each of the hospitals to see the service that was provided and the limitations, so I won't go into detail into this. So the project, so after this study, the project that was planned was, so we have different barriers and different levels. We cannot intervene in all of them. So what we found most feasible was at least to improve the tertiary delay. We can improve communication between hospitals and improve the referral of pediatric surgery patients timely referral. So the concept was, one is to develop a software that would aid in this communication in between hospitals. So this software or web-based system would have each of the pediatric surgery centers registered, and even if the pediatric even if the pediatric centers are there, they might not be able to provide all of the services, like some might not have bronchoscope, cystoscope, or ICU. So it should also entail which services are available at each of these pediatric centers, and also daily updates should be done on whether bed is available. So we believe this would aid in the communication in between hospitals. And the second one is to develop a guideline and train this frontline providers, the primary health providers. So this might be health officers, GPs, or pediatricians who are first seeing these patients. So we need to prepare a guideline for at least the most common cases with a focus on emergency cases, and categorize procedures and stratify them, like which can be done by general surgeons and which require pediatric surgeons, and on how to optimize some select emergency cases before referral. I don't know if you can see this. So this is a proposed specification for the interface. So it's supposed to show real-time data on which centers are pediatric surgeons and which specific procedures are available, and also it should filter them by distance, so that patients should be referred to the nearest available center with adequate facilities, and it will also be a means to communicate, so the software can be used to communicate directly to the referring hospital. So I'd just like to show you a brief demo of what the system looks like. The basic feature, and also to have your input on what should be improved and whether we can apply this in our hospitals, because it requires cooperation from each of the hospitals that are providing this service.
Questions to the first about the standard training.
Questions for the presenter, for the first presenter, for Dr. Rajiv?
Thank you. It was a nice presentation. So my question, the recommendation I can take to explore the whole board of anesthesia. You see, I think we have to explore the whole board to see whether there is anesthesia or not for all patients. So what I was thinking is the prevalence of anesthesia in oncology. So the rate is not that much, and usually the decision is the abdominal effect is small. To explore the whole abdomen, so are we going to explore all patients with oncology for anesthesia, considering the prevalence in the
Any additional questions?
Did the patient have vomiting?
Anyone else? So, Dr. you can stop.
The first question, most of the anesthesias have most saturated segments found in the sac. So sometimes we don't find that really in the sac. So before we close, we can at least see some part of the power. We can pick it up and see. And there was no need, almost every case, there was no need to extend the incision than like us to see the whole of the segment. And one thing is, if there is an atrophy segment, there might be, we see the dilated segment of the bowel, or sometimes if there is a operation, or maybe signs of obstruction. If there is a sense of obstruction, most probably we have to see the whole, otherwise there is no need to extend with a larger incision. I showed both. There was certain house only, there was no thinking. But there seems to be signs of obstruction. There was no voiding dilated for Lucy, but there was no.
Did you do ultrasound? You did? No.
I don't. It was, for the other animals. You before the operation?
Yes.
No. It wasn't. But after the operation, which was coming, there was one other animals that were not
So the process for the next presenter, Dr. David.
The common site is the junction between cystic duct and the CVD that usually gets perforated. How close was that towards the CVD? How many centimeters was it?
Book you can see it was the biliary ascites was navalt and cholecystectomy was done and the patient did fine. It was discharged the fifth postoperative day. It was fine the postoperative oral. Like we were following this patient, it is fine, it is well traveling, it's fine. And the commonest perforation site is actually the junction of the common hepatic duct and the cystic duct. That's actually the commonest sites of extrabilary spontaneous extrabilary duct perforation. That's really the most literatures. It's because of time. I said the process. Cholecystectomy and lavage.
I got that. Because cystic duct joins it's the junction, right? The common site. So how far is it from that side?
It is just cystic duct perforation, almost near to the gallbladder neck. It was not distant, it was proximal. Then we were able to ligate the cystic duct. It was not difficult to even to ligate the cystic duct.
Thank you. So I think we are much behind time, so we have to shorten it as much as possible. But one or two final questions because it is a very interesting topic for Dr. Sam. Two questions.
Yeah, please. Thank you. So just to briefly demonstrate what I'm working on. So one of the challenges is, so the training is expanding, so new hospitals are opening up with pediatric surgery centers. So it will have the map embedded in the system, so in the future it will filter the results by distance also. So when you decide to refer, the hospital that's deciding to refer to you would input some basic patient information like name, sex, and what the service is required, and maybe the chief complex or the main diagnosis, and will select the hospital and then refer. So this is the page that is displayed for the hospital that is going to make the referral. So the hospital that's going to be accepting the referral will have this list, and then they will decide whether to accept or reject. So they can accept here. So then, once they are accepted, until the patient arrives, there is a waiting list. So the patients will be listed here, and emergency and elective surgeries will be separated. Emergency and elective referrals, so they will be listed here, at least for a period of time. Emergency surgeries might be visibly here for 48 hours or so, and if they are still not coming, they will be removed from the list. And this is the user interface for the hospital's pediatric surgery service, so we will have to update each of their facilities. For example, the availability of neonatal ICU, if it's not available, they can set it as unavailable. If it's available, they can write down the quantity of beds and they can update it. They should update it regularly. So this is what the system looks like briefly. So it's under development, both the design and the functionality that are expected to improve.
So now we have our lunch break. We have 1 hour until 2:30. On your way out at the registration table, please take your coupon. Lunch is at the traditional level.
ዛሬ አራት ፓናሊስቶች ከኔ ጋር እዚህ በቁጭ ለዲስከሽን ያደረጋቸው አጀንዳዎች አሉ። ለዲስከሽን ኦፕን ስናደርግ ደግሞ ሜምበሮቻችን ከእናንተ ሳይት ሪፍሌክት መደረግ አለበት የሚሉትን ነገር እንቀጥላለን ማለት ነው። Why are we raising these issues in the community? ኢትዮጵያ ብቻ ስለሆነ 13 የሆነ ኮሚኒቲ የሰርቪሱ አይገለጡን አንደር ሰርቪስ ነው። ስለዚህ all hands in deck አለ ካሰራ we are going to change the system. So unless the system changes, we are going to improve the service. So all the stakeholders, care providers to the pediatrics, support staff from the administrators or policymakers, NGOs who is working to improve the safety of patients, we should work hard in improving the service to our pediatric surgery. So this will help in solving the problem. Unfortunately, unlike adult patients, minimum collaboration can serve a lot of pediatric patients with significant improvement in their complication compared to adult care. So cost effectiveness, timely management, as well as improving in the system and structure is easily addressable when it comes to pediatric surgery if we work hard in that. So fortunately, we do have good specialists and subspecialists in the country to address the sustainability development goal of the United Nations, the WHO, and also the Ministry's flagship. We can work together. So I will call upon our 4 panelists to reflect on what is the challenge, what are the best lessons we get, and how can we improve the system together. The first panelist is Dr. Dari Nayu, a pediatrician working at Blackline Hospital. He is a subspecialist in pediatrics, oncology, and hematology. He is an assistant professor of pediatrics and childhood at Addis Ababa University, Department of Pediatrics. And he has got his subspecialty in pediatrics oncology from different institutions, joint training at Sarah University, University of Toronto, as well as National Institute of Immunology and Pathology in Mumbai, India. For the past 20 years, he has been serving the country in different positions, has been being general practitioner and also being subspecialty in pediatric surgery. He has multiple leadership positions. He is the head of East African SIO Research Committee, Chair of Department of Research and Publication at Department of Pediatrics, and also the Head of Pediatrics Oncology and Hematology. He has played in the establishment of Pediatrics Oncology and Hematology Fellowship training at Blackline or at Sarah University College of Health Science. He has been involved in more than 15 publications in peer-reviewed journals and has presented in different conferences and national and international level. Unfortunately, Dr. Dali couldn't join us in person, so he's going to present virtually and he's going to participate for the discussion virtually. So I call up on the next panelist, Dr. Nasser Latafare. He's a senior pediatrician and neonatologist and an associate professor of pediatrics and childhood at St. Paul Millennium College. Has been graduated as a general practitioner at Juma University, and he got his pediatric certificate at Sarah University, and he became a neonatologist at St. John Smith Medical College in Bangalore, India in 2018. In the past 16 years, he worked at St. Paul as a general practitioner as well as pediatrician and also now as neonatologist at the department. Currently, he is actively working in pediatric surgical team for neonates with surgical condition to improve the system. He is the vice medical service of the head of pediatrics in childhood, as usual I can shout. So he has been involved in different presentations at different conferences, and Dr. Gassel has published more than 10 publications at different peer-reviewed journals. The third part, Dr. Gassel, I collaborate to the The third panelist is Sister Judith Unax, a compassionate, exceptionally organized nurse expert. She has been practicing nursing for more than 10 years. She has specialized in providing complex critical care for pediatric patients, especially at ICU. She has ample experience in nursing. She worked at Monaita Hospital as teaching staff in different private hospitals and now at pediatrics department in Lakeland Hospital. She is dedicated, compassionate, and humble nurse who helps patients with good hearts, and she has been participating in helping a lot of patients and creating a smooth environment for the working team. Now I call upon Sister Yuri to the podium. The last but not the least is Dr. Samuel Sisal. He is a senior pediatrics radiologist at Addis Ababa University. He is an assistant professor of radiology. He has been working at Addis Ababa University for long year, and he has been with the Department of Radiology, and he has got his fellowship and joint training from Addis Ababa University as well as Children's Hospital of Philadelphia. He is a dedicated professional with high clinical value, great leadership, team leadership, as well as longevity and pursuing options for good medical service. Dr. Sami has received his medical degree from University of Gondar. He completed his residency as well as fellowship at the same time at Addis Ababa University. At the end of his residency, he has been awarded with Whitaker Award as Best Graduating Resident. Has been involved in different academic leadership positions, also research activities. He is the current clinical lead of radiology department. He is one of the passionate leaders in the implementation of ultrasound-guided hydrostatic reduction for susceptible patients. Currently, he is also involved in medical artificial intelligence researchers. Dr. Sami has published more than 10 publications in peer-reviewed journals and also involved in different presentations. Now I can appoint Dr. Sami to the podium. Thank you, everyone. Saying that, so today we have got a bigger agenda to cover and a big panelists to participate and to contribute. So your contribution also is remarkable. We are going to use Guramaide language, so try to express yourself as whatever you want to express in whatever language. So the first presenter who is going to present about the experience of MDT establishment at Lakeland Hospital is Dr. Daniel, and Dr. Daniel will present in Zoom. Dr. Daniel, can you hear me? Can you hear me, Dr. Daniel? Can you try once? So to be time conscious, I will continue with the other panels until the system starts to work. towards neonatal surgical care, and he will share us his views.
Thank you, Dr. Tana, for your generous introduction. So, working jointly with the pediatrics and gastroenterology is very, very important thing, because we have a lot of neonatal surgical conditions. So we need to work in hand in hand so that they can improve the survival of the neonatal. So, what are the surgical standard just to practice and to have optimal care for the neonatal with surgical condition? What could be look like? So I will try to see some of the things should be fulfilled before we run surgical case management in neonatal age groups. So first we need to see the organization, what we like the organization is, particularly organization symptoms, especially the NICU setups and then the surgical pediatric setup also should also take into considerations, and if possible also at least separate the room for pediatric patients should also have the level, because there are a lot of issues in tranquility also that can also takes place. So separate the room if possible, otherwise just dedicate the room for pediatric surgical and neonatal surgical care should be there. And the other thing is just the NICU and the pediatric surgical staff should work hand to hand, and should also conduct review, especially the monthly review should be done. So what should be the outcomes, the procedures, and the other things. And even annual review of the data should also be mandatory to have just optimal care, and to see also, to learn also from the data that we have identified. The other just staffing, we see the staffing of the serious neonatal surgical conditions. So we need to have at least pediatric surgeon, which is competent enough and able to handle both preterm and terminal newborns. And anesthesiologist should be also there, and every consultation, at consultations, everyone should also there, especially the radiology department is paramount and very important. And okay, so at any time, so surgical department, radiology, from the radiology department, we need a lot of help so that always they should be also available at any time, whenever we need, so they should come in and intervene the patient so that on-time intervention can also given for the newborns. And the other surgical specialty should be also fulfilled, okay, not only, so we need to also take into consideration that. The most important thing is the nursing issues, okay, so especially the intraoperative and the post-operative periods, even one-to-one patient to nurse ratio may not be educated. As a standard, at least I need 2 nurses for 1 patient, because a lot of things can be done. Critical patient, immediate post-operative periods. So these 2 also should be taken into considerations. The other, when you see the facility-wise, so we need to do something, especially operating room shall have capability of monitoring, especially the temperature regulation, which is really very, very important, and it has also faced now in that here is there. So most of the baby intraoperative or immediately after post-operative period, so usually we do hypothermia, so the room should be convenient for the newborn to take care. And even the thing is, especially just mattress, the thermal mattress, radiant warmer, and the room temperatures in standard room for surgical intervention should be also optimal. So thermometers also, the operating room should also take into consideration. The other, especially the continuous monitoring of the vital signs, particularly the arterial respiratory, blood pressure, just continuously also need to monitor. This should also, the facility should also have these things in place. And the other, especially blade, I don't know, I'm not sure just how much of the OR is, I believe the blade is available. Otherwise, we are giving just 100% oxygen for everyone, especially for premature baby, at highest level of retinopathic prematurity. So the blade are giving the capacity that give also should also work and humidify it. And this facility should also avail these things. And the other thing is there are different equipment, especially for pediatric or neonatal surgical, like the different equipment like commercial labels, like for example, if you have gastroenteritis, so you have equipment or instrument that we need to also cover. And the other, particularly the most important thing is also the intravenous access. So usually it's really very difficult things, okay, between the neonatal ward or sometimes in the surgical or room is really very difficult. Okay, we have a lot of patients who have a difficulty to access, especially just the peripheral line, peripheral insert line or femoral lines, and especially the peripheral line are not adequate either, particularly if you undergo surgical interventions, so lots of line, more than one or two lines may be there, may be necessary. So if you have a central line, that will be very, very important. And the other thing is the blood is also an issue. So we may not always here that platelet or that papillary receptor available, so that will be also the issue. So facility-wise, so this thing should be taken into considerations. And the other thing is that we need to take into considerations the performance evaluations. So usually, I don't see this thing, especially probably like I doing such kinds of things. So it's a gap that we identify. So there is no gap. So there is no performance evaluation. So we did the surgery. We follow the patient just separately. Just we don't allow teamwork, just strong teamwork. So we need to work in teams. So we need to review the data monthly and even annually. So we also learn from our success, from failure, and other things should also take into considerations. So medication-wise, so the other thing is that we take into consideration, so especially the medication-wise, so the pain management that we are very supportive pain management, starting from the narcotic and like the narcotic, and the other, so even just non-pharmacological treatment for the pain management also really lucky. So we also working hand in hand so that we can increase the safety of the surgery, the good parts of that. We will go under those interventions. The other, which is really very important, it has also an impact on the outcomes of the surgical intervention, the presence of absence of total parenteral nutrition. So we don't have, especially if it's a people of any pediatric age groups, so if the child is malnourished, if the protein level is low, how can we expect the eating is outcome? So okay, we did a lot of surgical intervention, but without optimal nutrition support, we don't expect them to make it. And if the patient survive, so that it doesn't really compromised. The other basic laboratory studies also. So there are also a delay, especially availing that the laboratory service will also available here and there. So that could be also an issue, should be also fixed. The other, after we did the surgery, after the patient is out from the hospital, so follow-up should be arranged so that we need to work hand in hand. So multidisciplinary team involvement should be also the pediatrician, the neonatologist, developmental supportive care, the orthopedicians, and even the physical therapist. So all these things should be also taken. And the other thing, the most important thing is most of the time you are the surgical condition, especially congenital acquired congenital malformation, you are end up in malnutrition and other things. So usually the growth and the development of the people should be followed closely so that we can increase the outcomes in several needs. Thank you.
Thank you, Dr. Gasset, for using your time properly and reflecting on the important things that the unit is expecting for the care of these patients. So, as been said, properly evaluating what has been done, allocating space, and looking for the necessary resources is one of the agendas we should be interested in as a joint session, as well as at the unit level. So thank you so much. Can we continue with Dr. Daniel or Walker? So Dr. Daniel, can you try now? As you all know, it's been a known fact that nurses play a very pivotal role in the care of patients, not specifically pediatric patients. But when it comes to pediatric patients, literally the family as well as the patients are relying on their service. So we do have an experienced nurse with us who's going to reflect what should be the role of nurses in the care of pediatric surgical patients. So I'll give the floor to Sister Judith.
Thank you so much. Role of nurses in pediatric surgical patient care. Nurses play an important role ሮል ኢን ኬር የሚላቸው ሰርችካል ሜጀር እያስኳቸው ነው። አጠር አድርጌ ስለሆነ ብዙ ሊሆን ይችላል፣ ግን አጠር አድርጌ ነው። First, promote health habit and proven practice for preventive care. ለምሳሌ personal hygiene, nutrition, and preventing infections, hospital acquired infection, health education እንሰጣለን። Then recording comprehensive health history እንደ ሲመጡ አሰስመንት የምንሞላው ሂስትሪ እንወስዳለን እንደመጡ ማለት ነው። And focus physical examination እንዴ ጃምስ ነው ሲያንስ ነው የሚለው ፊዚካሊ እኛም በነርሶች የምናያቸው ነገሮች አሉ። ከዛን ፊዚሻን ያው የራሱ ኦርደር ስላለው እኛ የምንሰራቸው ነገሮች ናቸው። አድሚኒስተር ኦርደር ሜዲኬሽን ኦን ታይም ኤንድ ትሪት ኢልነስ ኦርደር የተደረጉ ሜዲኬሽኖችን ኦን ታይም የምንሰጣቸው and then follow up whether patients are taking the medication or recommended treatment based on laboratory and diagnostic tests. ሜዲኬሽኖችን አንዳንዴ የሚቀየሩበት ጊዜ አለ። እሱም ደግሞ ላቦራቶሪ ታይቶ ዲያግኖስ ተደርጎ ምናልባት የሚቀየሩ ሜዲኬሽኖች ካሉ ያንን አይተን ለምን ተቀየረ የአይዲያውን ላቦራቶሪ ውጤቶችን አንዳንዴ እናያለን። ዜን establishing treatment and plan with doctors ፕላን ከዶክተሮች ጋር አንዳንድ የሚያስፈልጋቸው ነገሮች ለምሳሌ ኢነማ ቢያስፈልገው ያ ፔሸንት ከኛ ጋራ ኮንታክት ኖሮን ያ የሚደረግ ኮንስቲፔሽን ኖሮን ይህ ፔሸንት እንዲህ ያለን ኢንፎርም እናደርጋለን። ዜን የሚደረጉ ነገሮችን ያንን እንሰራለን ማለት ነው። ሌላው ፕሪና ፖስት ኦፕ ኬር አለ። ፕሪ ላይ ፕሪ ኦፕ ላይ ብዙ እንትን አለ። መጀመሪያ የምናደርጋቸው ነገሮች አሉ። ለዛ ፕሪፔር የምናደርጋቸው ነገሮች ለምሳሌ ፋሚሊውን ሪያሹር እናደርጋቸዋለን ማለት ነው። ፋሚሊዎቹን ዜን ሴኪዩር ላይ ሜንቴናንስ ላይ ማድረግ አለብን ፕሪፔር ሲደረግ። ዜን ጊቪንግ ኢነማ ካላቸው ያላቸው ችግር ካሉ እነሱንም እንሰጣለን። በመቀጠል ኮሌክቲንግ ሳምፕል ላቦራቶሪ ኢንቨስቲጌሽኖች ኮስማቶች ምናምን እሱን እኛ ነው የምንሰራው። በፖስት ደግሞ ስናይ ፖስቶፕ ላይ ከመጡ በኋላ ሞኒተር ቫይታል ሳይን እንደመጡ እሱን የምናነሳው ነው። ዜን በመቀጠል ጊቭ ፖስት ኦፕ ኦርደር ሜዲኬሽኖችን አንቲፔኒክ ወይም አንቲባዮቲኮችን እንሰጣለን። ሌላ ደግሞ ኦብዘርቭ የምናደርጋቸው ነገሮች አሉ። ለምሳሌ ቸስት ቦትሊንግ ያለው ካለ ወይም ድሬኔጅ ያላቸው ካሉ ወይም ስዌሊንግ ካለ እነሱን የማየት እንትናል አለ አይተን ኢንፎርማል ያለ ፓተርኖች እናደርጋለን ማለት ነው። ሌላው በመቀጠል ፎሎ ፔሸንት ትሪትመንት ፕሮግረስ ፔሸንቱ ትሪት እየተደረገ ያለ ምንም ለውጥ ከሌለው ለምን ሆነ ኢንፌክሽን ጨምሮበት ነው የሚለውን ነገር እነሱን እኛ ስለምንሰጥ አንቲባዮቲኮቹን ምናልባት ለውጥ ከሌላቸው እንዲቀየር የሚለውን ነገር ያው ሐኪሞች ጋር ራውንድ ስለምናደርግ እዛ ላይ እንሰራለን ማለት ነው። ዜን ሌላ ደግሞ ፋሲሊቴት አድሚኒስትሬሽን ትራንስፈር ኤንድ ዲስቻርጅ ፕሮሰስ ኤንድ ፔሸንት ዲስቻርጅ ሲሆኑ የዲስቻርጅ ፕሮሰሶችን ፋሲሊቴት የምናደርገው እኛ ነው። ሌላው ካውንስሊንግ ፋሚሊስ አባውት ኒትሪሽን ኢንፌክሽን ፕሪቬንሽን ኤንድ ፖስት ዲስቻርጅ ፎሎአፕ ሲኖራቸው እነኝህ ሮል ብለን ሜጀር ያልናቸው ናቸው እንጂ በዛ ውስጥ ብዙ የምንሰራቸው ነገሮች አሉ። አጠር አድርጌ ስለሆነ ነው። አመሰግናለሁ።
So she again used her time properly, and as you all heard, nurses contribute a lot around prevention, around treatment, around management and diagnostic opportunities, and properly aligning what's happening to the patient with the physician's care. And even during discharge, they will play a role that the patients and the parents know what the follow-up plan is. So in counseling, preventing and management, they have got important role for the community. So the next presenter is going to be, okay, let's try one more time Dr. Daniel's presentation. So Daniel, you can try now.